get started. I'd like to welcome everyone to the AO Trauma North America Journal Club on subtrochanteric femur fractures for this month. I'm going to try to get through these intro slides fairly quick, so there's a lot of content in this webinar, but I'd like to welcome everyone. Here are moderators. I'd like to thank everyone for their help in getting this put together. And here are authors. We've got quite a lineup today, so that's why we want to kind of get to the meat of the journal club. But I'd like to thank everyone for participating and taking their time out of their night to supply their expertise in subtrochanteric femur fractures. Here are a disclosure information. The AO is an educational activity. They don't have any financial disclosures. This is educational purposes only. AO North America is a nonprofit organization. This is for education only. It's not to promote any products or any techniques. It's just to provide an educational experience for the participants. Zoom, you're muted and your cameras are off. If you have a question or you have a question that you want answered or presented to the faculty, use the question and answer box, and we'll be reviewing all the questions and asking our experts as we move forward. Here's our agenda today. Like I said, it's pretty jam-packed. We have 3 videos that are recorded. We'll have a live tips and tricks session with Dr. Christ and possibly Dr. Opie. And then at the end, it'll be a question and answer. This is where you type in your questions in the question and answer box. And then we'll also be asking the faculty questions. And then we'll wrap up at about 9:15 Eastern. Our objectives: to review current and classic articles, why the studies were conducted, what do they show, and how has treatment for subtrochanteric femur fractures advanced over the last 30 or 40 years. So this is where we're going to get started.
All right. So my name is Kyle Schweizer from the University of Missouri, and I'm fortunate to be joined by Dr. Afsari from St. John's in Detroit. And we're going to be talking about clamp-assisted reduction of high subtrochanteric fractures of the femur. So we appreciate you being here with us. And why don't you give us just a quick summary of the article and its findings?
Glad to be here. Thanks for inviting me. Very much appreciate it. So, yeah, this was a retrospective study that looked at about 50 low 50s number of patients who all had the same technique for management of their high subtroch fracture, where the deforming forces were the typical for a subtroch, and basically the strategy was to realign the proximal segment to assist with proper nailing so that you have an optimal starting point. And a few of the fractures had an addition of a cerclage, and we had a high union rate. And the cerclage in this study turned out not to be the quote-unquote instrument of the devil, and did not negatively impact union rates. So it was a pretty short study, pretty concise paper that looked at this subgroup of fractures. And we had good union rates and clinical outcomes.
So I guess why did you guys decide to start using cerclage? Because I'm sure around this time when we're going to publish this paper, it was considered a little bit of heresy to kind of open these up and quote strip the tissue away from the fracture and stuff.
Yeah, well, this was a fellowship project. So early in the fellowship year, the trauma fellows and the trauma attendings got together to for a research meeting, and a bunch of ideas were brought up. And Dr. Heidekevich, who was one of my attendings at the time in Tampa, who's now in Orlando, he had written a paper in 2001 looking at reverse oblique IT fractures, and part of it was just sort of, from his standpoint, an extension of that. He thought that was a good article that for a pretty common fracture, and having another paper about proximal femur fractures with a different viewpoint made sense. this was a point of contention, though. This clamp assist and or use of a cerclage. There were some of the attendings who said, that's a tourniquet, and you don't want to be publishing this, or you don't want to be looking at this because you're going to cause problems. But there was a group of attendings who were pretty dedicated to this mindset for the past few years. And so it wasn't my idea, it was their idea, and something I'd never really thought of as a resident. So they were convinced that the reduction made more of a positive impact on healing. And in reality, from a plate standpoint, if you go back even further to the late 80s, another sort of Tampa alum, Brett Ballhoffner and Jeff Mast had published on plating subtrochanteric, and they had a high union rate as well. So opening the fracture itself doesn't seem to be the issue, but having a good reduction and stable fixation made more sense to positively impact union.
You kind of touched on some of the highlights and takeaway points in your summary, but what do you think what's an aspect of this article that you think people miss when they read it, whether that's the weakness of it or a strength? Like, because sometimes we have subtleties in these articles and we write them that maybe there's a point that's maybe looked over a little bit.
Well, I'd like to think there's not too much to hide there. It is, like I said, it's a pretty short manuscript. I think implied here is we all have a mindset of what any fracture we're managing, what it's going to behave like. But when the rubber meets the road, I find when you're in the OR, you're going to have like your technical skills, your toolbox, and you need to see how the fracture behaves. So first off, this is really applicable to fractures that are deforming in this typical way for a subtroch, but I think it applies to even a distal fracture that you're retrograde nailing, or even a proximal tibia fracture, that you need to see how the fracture is behaving, and your reduction and fixation strategies need to be very much based on the behavior. So that was one of the things that we excluded, fractures that they may have been subtrochish, but they're really behaving like shafts. You don't really need to open those. So deal with the problem at hand, identify and deal with the problem at hand. So you have to see how it behaves when you're in the OR. And then the next thing is, you don't need to flip the vastus and do an exposure like that. It's really like splitting the fibers of the muscle right over where the fracture is and sliding the clamp in without completely stripping the bone. I would say use of CTs, and now everybody seems to get pan scanned now. And at some point in time, I wondered, why are we getting all these CTs? But they're so useful to help planning your clamp position, because especially for the oblique fractures, you can see where the apex of the fracture is, and you might have an incision out of plane from the lateral part of the thigh. You might go a little anterolateral, and you can get a clamp in position that's away from the jig, that makes the whole nailing more like a sawbones. So those are aspects. The idea is minimize the stripping, and I think nowadays using the CT to help with clamp placement, incision selection for that part of it is very helpful. Because what's not, the other bit that's not written in the article is, so frequently the ideal position of the clamp is right in the way of the jig, and it can be pretty frustrating to work around that. So when you can get it out of position of the jig, that helps.
What do you think is the biggest weakness of this paper, besides being, the typical retrospective stuff? But I think there's any other weaknesses that we could point out or discuss with the viewers here?
Probably also more implied is that really the starting point of the for your nail is still super critical. So because of the having a fracture near the driving end of the nail is I think makes that so much more important. So perhaps that's not well explained in the article. And it is a small group of patients, and there's no, there's no control group. So I wonder if we were to submit the same paper today, whether it would be accepted at JBJS. I'm gonna guess no. There's no proms. There's the typical things that the top level journals want. This paper doesn't have, but it's an easy read, and it kind of makes sense for most fracture surgeons, I think.
So do you think, do you remember the ones that went on to have the slight varus malunion? Do you remember if those was that like a post-operative loss? Is that related to the start site? Were they more likely to have the cables? I mean, I know it's a long time ago, or maybe you didn't look at that, but do you remember, like, was there anything about those that went into varus that you can remember that there was a certain characteristic associated with it?
It's kind of a long time ago. So
I know.
My best recollection is that, and if I were to apply it to what I'm looking at now with the, current patients, is I feel like you can, if you slide the clamp in, you've got it nicely reduced, and you nail the fracture, you loosen the clamp, and things look like they're well aligned, and probably there's a subset of those that still drift into a little bit of varus. And the measurement of varus in the study was kind of twofold, trying to note whether there was a measurable deformity at the fracture itself, but also whether the relative heights of the greater trochanters to the center of the femoral heads. So a lot of these fractures, especially in older people, the average age was like 55. So there's a lot of older patients. Sometimes they have splits into the IT region, or the whole lateral part of the fracture just sort of turns into it sort of abducts, I guess. And sometimes you wish you had a clamp after the fact, or you had a cable after the fact. Or nowadays, I think I'm more inclined to use a mini frag plate, even like a 2.7 recon plate. Seems to be enough to help aid these to stay in position. And I think it assists in the load sharing of the nail if you've got a better reduction, and you're relying on bone-to-bone contact for stability.
Okay, well, we appreciate you again being here and being willing to discuss your paper and your practice, and say thank you.
My pleasure. Thanks for asking.
So I'm Andrew Mills, and I'm here with Dr. Ostrom from UNC, and we're going to be discussing a critical analysis of the eccentric starting point for trochanteric intramedullary femoral nailing, which is from 2005 in JOT. So thanks for agreeing to do this. It's great.
Oh, happy to be here.
So I guess my first question is, reading the article, there's this line right at the beginning that's, the authors have noted clinically that some subtroch fractures reduce on a fracture table and then malreduce when you put the nail in. I know it's a while ago, but is there like a specific case or something that you remember being particularly like, I don't know, frustrated or something when it happened? Or is it just something that, you started noticing and kind of wanted to dig into? Or
Yeah, so I grew up and trained and started practicing through the 90s and early 2000s with just piriformis nails. So you got a reduction, and as we said in the article, you go central medullary, you go right down the canal, and it doesn't malreduce because whatever reduction you had, you kept. And then we went to these offset nails, and I guess the best analogy is doing a proximal tibia, and we can't go straight down the middle, so we have an eccentric starting point, and we get deformities. And what happened was, I started using trochanteric nails, and everybody said, "Oh, they're so much easier," and with fat people and muscular people, and we did it, and we thought we knew what we were doing, but like you'd put it in one time, especially in the proximal subtrokes, and it would look great. And you put it another time and it would be in varus. And then it was very variable. And the question was, is it the nail? Is it where we're starting it? Is it the fracture type? What is it that's so variable? Because we couldn't reproduce the same thing every single time. And we really wanted to believe that this was better than what we were doing. But in the beginning, I couldn't prove it. It was trial and error, and like everything in orthopedic trauma, you try it for a while, you screw it up, and then you go try and figure out why you screwed it up. So that's what we did.
Yeah. Yeah. Well, yeah, I really like the design of the study. You know, I guess coming back to what you just said, you know, after you did the study, were the results surprising to you at the time, or did you kind of did you go into it thinking that this was about what you were going to find?
You know, it's interesting, like the companies all had you can tell from the article, had a different proximal bend. And it was sort of, you know, when we use these plating systems that are all based on cadavers and stuff, and they say, oh, you know, one size fits most. And I couldn't figure out, like, why were these all different, you know, bends proximally and stuff. And so they, you know, draw a line down the middle of the canal, then they drew a line from the trochanter and intersected that, and they said that's the proximal bend. And I mean, I got all that, but, you know, there's a 4 degree, there's a 5 degree, there's a 6 degree, there was a 10 degree. So something had to give. And you know as well as I do, like, some people, I mean, trochanteric anatomy is really weird. Not only that, you know, people have short femoral necks, long femoral necks. Some people have Roland valgus, a lot of I mean, there's all kinds of variables. And I think that we just had a difficult time. So I think the idea was, like, if we could figure out one spot, you know, sort of what we did later on with the retrograde nail, one spot that would universally reduce it no matter what nail you use, that would be great. I didn't think we could do that, but I thought with the 4 to 6 degree nails, we probably could. And I think we got pretty close, but it was eye-opening to me that we just sort of, you know, were doing what we thought was right. All the companies had a different place to start, which was a little frustrating as well. And then I told the residents over the years, and I still believe, is I think one of the ways we get in trouble is, even if we put the guide pin in the all where we wanted to start, let's say the tip of the trochanter, and we bring that long guide rod out, and you have an obese or muscular patient, the guide rod deflects laterally. And so when we keep reaming, we're actually reaming eccentrically. And it happened to me in the beginning, like 3 or 4 times. I'm like, that wasn't, when I put the nail on, I said, that wasn't where I started it. Like, I started it more medial than that. It took me a while to figure that out too. So yeah, I mean, I was hoping we could find one universal. It's not, I think it's not quite as easy with retrograde nailing, because again, that's a centromedullary right down the canal. But yeah, I mean, I was happy that we could at least understand what we were doing right and doing wrong.
Yeah. Yeah. And one of the other things I liked about the study, and I wanted to ask you a question about it, is you at the end, you kind of talk a little bit about the anterior to posterior placement of the start point, because the whole design of the study is basically based off of like the AP X-ray. Was that something that you noticed, like, as it was going on, that it was maybe another effect or another aspect of it? Or, you know, did you like intentionally leave that out of the study to make it as like simple and pure as possible?
You know, my feeling is, and again, I've taught the residents over the years, that, you know, you can't really adjust for varus if you have it, but you can adjust for either apex anterior, apex posterior with your hip motion. And, you know, we've all done nailings where the proximal fragment's flexed, and we accept whatever 5-10 degrees of apex anterior, and patients do wonderful. They don't do wonderful if you leave them at 10 degrees of varus, and, you know, nails break and people limp like crazy. So part of that was we looked at the curvature of the nail, and that was another study we'd written looking at, especially in subtrochanteric, where the femur can't move around the nail, that Synthes was way ahead of its time. They had a 150 radius of curvature, which was actually really bowed, which was a good nail. Whereas when you looked at the gamma, it was, you know, initially it was like 300, and the tan was like 350. And so they were really, really straight nails. And I think that's part of what the deformity were. I want to believe that where we start, it's important, but I also think the curvature of the nail made a difference and caused the deformities as well. So I sort of still believe that if you start in like the anterior 1/3, it just makes it easier to put that cephalomedullary screw up into the femoral head without rotating the nail an awful lot. And I still, to this day, I still accept 5-10 degrees, in the lateral view. I just don't, I don't think that's clinically a problem, but I do think in the, when you're looking at it on the coronal plane, I really think they got to be as close to neutral, or even a touch of valgus would be great.
Yeah, touch of valgus. Okay. All right. The other things I liked about the paper was, you did it in intact femurs, which, kind of like controls for you had a good reduction and all those things. But you didn't put the screws into the head, right? So there's a little bit, I don't know if futz factor is the right word, but the depth of the nail sometimes affects it too, because it's where that, the valgus curvature ends up being, depending on where you put your screws into the head. I mean, I like that you talked about it, but I think the study was really, I guess, really pure for looking at it. From my understanding, the tip of the nail stopped right at the tip of the troch every time. So it's trying to be as reproducible as possible. Is that kind of
I agree with you. I mean, there's so many variables, and you just got to sort of figure out which, pick and choose your poison, which ones you're going to do and not do. And, I could have backed the nails up or put the nails down, and then it was dependent on the femur we were using. And I agree. And you're right. We did say in the article that how deep you put it will make a difference. But just for purity, and I agree with you, I couldn't reproduce the pull of the, the hip flexors or the abductors. So I said, look, what would happen if I had a perfect reduction and I reamed it perfect and then just saw what the nail did? And that's why we did it. And the reverse obliquity was just, as we said, what's the worst case scenario? Like, what's the worst thing that could possibly happen? And that's the one we all struggle with. So that was the reason for picking that one.
Yeah, I guess so. This paper was in 2005. So what is your, like, if you have a subtroch, like a reverse obliquity subtroch today, like, you don't have to go into like what nail you would use, but like, what's your setup? Like where, are you doing anything different than you did in this paper? Like what, just kind of take me through how you do it.
Yeah, I mean, I'm going to be a contrarian, but I do all my proximal subtrochs lateral. I fight with the post. I fight with the more traction I put on, I often get more varus, or I can get more flexion of the proximal fragment. If I put them lateral, then I actually get valgus of the proximal fragment. I mean, the rotation's on me, and over time I've learned how to do the rotation. You can get an AP with like a little bit of lesser trochanter showing with a lateral thoracoscopy, and then internal rotate about 10 degrees to get an AP of the knee with the patella center, and that gets you close. Other people say you can do it off a lateral to get a perfect lateral to knee with the condyle superimposed, and then same thing up top. So rotation's on you, but if you do them lateral, they're much easier. I usually start for the higher ones. I usually start just medial to the tip of the troch, and then I figure I'm going to ream to the tip of the troch, and then, like I said, rotation. And I've always said to the residents, like, it would be awesome if there was a nail that could correct like length, rotation, angulation. We don't have that, right? So so it's on us, right? So
yeah.
I'm willing to put them lateral so I can take care of the valgus, I can take care of the reduction. I'm then in charge of the shortening, and I'm in charge of the rotation. But yeah, that's how I do them now.
I got you.
But curious, have you or like whoever's in the journal club tried doing them lateral? Is that something anybody's ever tried?
So if I'm gonna open it, I do it lateral, and or in a big person, I do it lateral. I like it. I like it a lot for a lot of the reasons that you just said.
The other thing is starting point's much easier lateral than it is, supine. You really, really struggle, and I feel like lateral, I can almost say I'm a touch anterior and I can move it. Like supine, it's so hard trying to be in that plane. I find it easier. But I mean, the other thing is, like, if you really can't get it, then make a small percutaneous incision. I'll use the like a percutaneous Weber, or just some kind of small clamp without much muscle stripping. But again, that really depends on the nail and where you started, because if you didn't do it right with the nail and the insertion point and everything else, as soon as you take the clamp off, it pops apart. So it does help you with the reaming, so you're not reaming eccentrically. I think that's a good point.
Yeah. Yeah. All right. Well, I mean, those were, kind of the main points that I wanted to hit from the article.
So besides not putting cephalomedullary screws in it or anything else you didn't like?
No, actually, I thought this is like, I was reading this article and I was like, I work with residents. I was like, they asked me questions and I just want to like hand them this article and be like, take this article. And this is like why we do like most of the things that we do.
I'll be honest, the problem when you're an old guy, but the problem with, doing the choke nails when they first came out and then retrograde nails when they first came out was there was no playbook. Like these things came out and you sort of had to screw up and you sort of had to figure out what was going on and everything else. But I think it gets, it's easier when someone else has screwed up before you. Then your idea is, okay, I'm not going to do this, but I'll find another way to screw up. So at least if people can take some of the guesswork out, it makes it easier. And problem when this started out, there was no way to figure out how to do these things. So we figured it out. But I appreciate it. Thank you.
Yeah, no, thank you. Thanks a lot. This was great. Thanks for coming on.
And I appreciate your time. Thank you.
I'm joined today by Dr. John Reel, who's currently the program director of the Medical City University of North Texas and Texas Christian University Orthopedic Residency Program. We really appreciate you, Dr. Reel, for taking some time today to talk to me about your landmark article of intramedullary nailing of subtrochanteric fractures. Does malreduction matter? Thank you very much for joining us.
You're welcome. Thanks. It's my pleasure.
So, Dr. Reel, what was the motivation for you and your colleagues behind looking at this study? And kind of historically, what were kind of the things that led to the synthesis of this study and article?
Sure. So the main motivation behind putting this study together and going back and looking at our subtroch fractures was kind of noticing a trend in the delayed unions that we had in subtrochanteric fractures in having malreduction. And I think historically, varus malreduction had been paid close attention to in subtroch fractures, and even specifically as nailing became more popular and making sure that you avoided that varus malreduction. But the sagittal plane malreduction was a little bit less of a focus, and we felt that it was likely just as important as that varus malreduction. And in addition to that, the what qualified as a malreduction and kind of quantifying that angulation and in malreduction was never really done previously. And so we wanted to try and take a look back at our subtrochanteric fractures and see what degree of malreduction ended up leading to delayed union or non-union.
Absolutely. And from that standpoint, when you did look back, did it surprise you the amount of malreduction that it took, or was that something that was pretty anticipated by your team leading up to that, or what were your thoughts on that?
Yeah, we did in large part anticipate a 10-degree malreduction to be significant. We even thought maybe a 5-degree would be significant, and it didn't seem to be. And so I think it was in line with what we thought for the most part. Yes.
I gotcha. And looking at your results, especially what was interesting to me is that sometimes the amount of varus malreduction and apex anterior, the flexion deformity, didn't always necessarily line up equally. So it looked like in some instances when you had larger amount of sagittal deformity, it led to the same issue. I thought that was quite interesting. Is that something that you all anticipated too, or did you think that one would be more important than the other from that standpoint?
Yeah, not necessarily that. I mean, again, just going back historically, I think that varus malreduction was stressed a lot more, and so maybe had some pre-existing bias just based on the history of the way these fractures were talked about. That varus malreduction might be more important than sagittal plane, but yeah, we had some that were really well aligned on the coronal plane on the AP view that had that 10-degree or maybe even 15-degree malreduction in the sagittal plane that had just as much of a problem healing.
Absolutely. What were some of the biggest takeaways from this study for you, and how did they impact and influence your practice?
For me, really the biggest takeaway of the study is that malreduction matters in all planes. And so sounds like a simple thing, but so easy to forget, even when you know it to be true. So making sure that you're well reduced on both the AP view and on the lateral view in the subtrochanteric fractures. And I mean, I think nailing just in general, we think of it as secondary bone healing. So as long as we have things kind of somewhat in line, they're going to heal. But in certain fracture patterns, even though that overall mechanical access may be better of the femur, just not having that fracture site lined up well enough at an area that traditionally has difficulty healing really makes a difference. And so I think the main takeaway point is making sure that you're reduced in both planes. And as a next step to that, I think the next thing that at least in my mind immediately pops into question is, well, how do you do that? How do you get it well reduced in both planes? And so the things I think about in these cases, a couple of things are, number one, starting point, I think, is the most important thing. And I think similar to a proximal tibia fracture, I think these proximal femur fractures that you nail, that's really 90% of the case. And if you get that starting point right, you're going to be a lot better off. And so, a lot of people have talked about getting that starting point medial or avoiding a lateral starting point in your coronal plane. And I think that's very important. And the articles that have kind of gone through that, I think, have been landmark and important for subtroch fractures. But I also think that where you get that starting point in the sagittal plane is important too. And so just making sure that you're where you want to be there, and that you avoid that anterior starting point that's going to cause you that malreduction in the sagittal plane.
Definitely. Yeah, it's interesting to think about how far we've come, even in the past 2 decades for these injuries. I think our thinking has certainly shifted quite a bit. And I think we're doing a better job of fixing these, but studies like yours really kind of led the way in thinking about these more in a complete fashion. So I really appreciate you taking the time today to talk with us. And I look forward to hearing further discussion in the live meeting too. Thank you.
All right, those are great interviews. I think we're going to toss it over to Dr. Sweezer and Dr. Christ for a tips and tricks discussion.
Wait a second.
Oh, you're going to go first?
We're going to jump the line.
Okay.
Special guest. He gets, I think, the award for farthest traveled for this webinar. Dr. Andrew Oppie is joining us from Melbourne, Australia, from Orthosport Victoria, talking about his article on subtrochanteric fractures and the effect of cerclage wire, kind of already been alluded to a couple of times in the previous videos. We did record a video for this while we were in Davos, but the video had some technical difficulties, so we figured we'd pull him into the queue and go through his article quickly and include him in the panel that I'm also excited to see how it pans out. So in brief, Dr. Oppie, can you kind of set the stage for what was going on in the time in your group's practice that the cerclage was something that was coming into play, and then kind of summarize the main findings from this study?
Yeah, sure, Adam, and thanks very much for inviting me to be involved. It's a fantastic journal club you put on over there. I wish we could replicate this back here in Australia. So it's a shame our videos have gone missing, or maybe it's been filmed upside down with me down under, or something's gone wrong. But yeah, look, there's a paper we published back now, and it was a period of from 2007 to 2014, and it's again the beauty of AO. Really, it was when I was teaching on a course in Asia when I saw the what was new to us at the time, anyway, the minimally invasive cable passer. And really felt that it sort of did revolutionise the application of sort of cables in these sort of fractures. And we've always been quite aware of that sort of the relative risk and theory on the soft tissue stripping, reducing a fracture in an open fashion with Haygroves, and then wrapping the sort of cerclage wire and trying to get the big passer around and passing that cable. So that led us to really, we'd been doing this for about 7 years using the percutaneous MIPO set, and we thought we'd review our findings because we did feel that they were sort of better. And it was quite interesting that over that 7-year period, we were able to sort of identify appropriate 135 sort of cases, subtroch fractures fixed with a nail. And basically about 50%, interestingly enough, were treated with some form of open reduction, and the other 50% treated with a closed reduction. And of the open reduction, so we had about 15% that had the associated cerclage wire. Results, and the primary outcome really about finding an unplanned return to theatre for revision surgery. That the majority basically went on that needed revision surgery. About 15% needed revision surgery from the open fractures, and these were the ones that did not have wires. And so they went on reviewing all these cases from a radiological point of view. It was found that, in fact, by trying to achieve the best anatomical reduction of these fractures, as has been previously discussed, I've been listening in on all those great talks, and really stopping these fractures falling into varus and getting as much bone stock available, we had the best outcomes. So there weren't issues in terms of avascular bone or non-union due to the wiring technique. So the new sort of MIPO wiring technique was obviously working well in terms of the soft tissue sort of minimizing their footprint there and giving us the best sort of reduction, and then relying on those Keffer-medullary nails then to do their job and allowing these fractures to heal. And so that's really a quick summary of our paper and why we did it, and it's something that we're continuing to do. Most of us here in the discussion previously in our institution do these on a traction table. Occasionally it will be done free lateral, again for the reasons discussed, on larger patients or one of our surgeons' preference, but otherwise the majority are done supine. Small lateral incision often sometimes look at the same place where you think you're going to be placing your Keffer-medullary screw as well, and you can do that reduction. But again, the big key, and I think it's the key to all these sort of subtrochanteric fracture talks, is that the fracture's got to be reduced before you put the nail in it, and using the cerclage wire is an assistance in allowing us to reduce those fractures before nailing it.
Thank you. Well said. And Joe, we'll now turn over to Dr. Swayzer and the kind of the tips and tricks / question and answer portion, and then the open panel discussion. Thanks, Kyle.
Yeah. Thanks, Brett, for being here with us. I think one valuable question to people watching is what are common mistakes that you see people make when treating these fractures, especially when they're first kind of out operating on their own, or maybe when they have left fellowship and they're used to having a lot of hands and they get out by themselves? Like, what are some common things you see people do, and how can they maybe avoid those?
I think the nice thing is that some of the panelists and interviews have already kind of said some great tricks to have. And so I think usually people don't get good reductions for, sometimes it's because the patient's too big. Like if you have a 600-pound patient, you can't x-ray them like that. You should get a little bit of a break for that reason. But I think, not looking into alternative ways of doing it. So like Bob had mentioned, like, do the panelists do lateral? I only do subtrochs lateral now because of the pain that I had in doing them supine. And so I think if you've never done it supine on a radiolucent flat top with a beanbag, or however you position the patient, not directly lateral, but rolled back a little bit, I think if you haven't done it, it'll be an eye-opening experience, for the reasons that Bob had mentioned. Reduction's easier, nail position start point is easier, kind of everything's easier, whether it's a large patient or a small patient. I think the other thing, I used to say cerclage wires were tools of the devil when I first got out of fellowship 18 years ago. And with the advent of the minimally invasive percutaneous wire passing set and other sets, or doing it just really biologically in a friendly fashion instead of just like, scorched earth, passer around the femur, and then putting 20 cerclage cables like that. That's not the way to do it. Just like any other part of fracture care, if you do it in a biologically friendly way and do it with nice dissection, and do it carefully, I think you can use cerclage cables like with the standard sets, but I think the minimally invasive passing set has also just changed kind of how I practice, and using clamp reductions. I think that the concern that people may have if they haven't trained with those techniques is that they're like, well, I can't open it. I get frustrated. I can't get my reduction. So I'm panicking and I'm getting the nail down just to avoid having the patient in the OR for 6 hours, or, having something bad happen. And so I would say however long it takes you, as long as the patient's doing well, reduction is the most important thing. And especially I think in these geriatric patients that have lower energy fractures, but large spirals, you need to get them reduced or they will displace late. And I think having cerclage wires, or, if you can get them to stay with a clamp reduction, I think I've had the same experience Bob had, like you take the clamp off and then it changes position, especially if the nail's not filling the whole canal, which is uncommon, especially in older people. I think also for me, I've gone to only, and I hate always saying like never, only, always, but for subtrochs, I only do them lateral unless they can't go lateral. And I only do piriformis entry nails for the reasons that Bob mentioned. You're down the pipe, it doesn't displace the fracture. There's ways to manage the potential change in reduction with the troch entry nail, but I just choose to always do a piriformis entry nail. And there is a concern in older patients as far as the Z effect, but that with the screws, as far as one going out and one going in, but that was in intertroch fractures, and I haven't seen that really happen with subtroch fractures. I like Bob's tip about rotation. I think I'm perseverating over that lately and do the true lateral technique, where you get a true lateral of the knee and like he said, overlap the condyles and an axial lateral of the hip. I think you can use the nail anaversion technique for the screws for troch entry nails, but for piriformis entry, the entry side into the neck is always posterior to the axis, where troch entry is more in line with the shaft. So I don't think that technique is as helpful for piriformis entry. And I don't know. Do you want me to keep talking? I can still.
I mean, I can.
Maybe we can get some other folks' questions or comments after what I said, basically.
I've got a question.
Sure.
Close reduction with slight malreduction, or open reduction with a percutaneous or a perfect reduction? What would you rather have, or what would you rather do?
So it depends on the type of fracture. So spiral fracture in a 70-year-old, it's getting a perfect reduction, the best that I can get, because they take a long time to heal. It's not like a 25-year-old subtroch. It's usually different injury. So if it's a comminuted subtroch in a young person, then it means it's comminuted. So you're not going to like put mini plates on. Typically you're going to try to avoid damaging the fracture more, but I would still make sure the alignment is right, whether that's with, application of joysticks, like that would be a percutaneous method, where you can place Chance pins. There's always room in the proximal femur behind the trochanter. And then you can put it in the shaft unicortically. But I think if it's an older person or it's a simple fracture, I'm trying to go for primarily anatomical reduction. If it's a comminuted fracture, then it's more of the idea of making sure the top and bottom are appropriate. So length, alignment, rotation overall.
How about the other panelists?
Yeah, I think great, all really good points from Brett as normal. And I think just even in the chat, there's something about sort of anatomical reduction and soft tissue, sort of open reduction. What do you do for soft tissue damage? But I think really it's about basically these patients often are being kind of cut and then stripped in terms of their muscle attachments, and I think that's what we're trying to avoid. Even if you've got to do respect the muscle attachments, the soft tissue attachments to these fragments. So I'm normally aiming for essentially as close as I can get to anatomical reduction, but also really before I'm just opening it, I'm going through all my percutaneous techniques of putting in little levers, shants, pins, bone hooks to pull, push, and around with really small incisions to start with. And just normally you can actually fiddle these things back into a very close position, and then a cable if it's appropriate to help get that sort of reduction before you're putting the nail in it. It's interesting hearing Brett talk about the entry points, and we always worry about varus, obviously, and so I personally always am using a cephalomedullary nail for these, but I actually am aiming for nearly a piriformis fossa entry point, and using the nail to absolutely try and help me achieve as much valgus as I can, and you're aiming out laterally anyway, so you can sort of never get sort of medial enough. So that'd be my little tips based on the discussions we've had. But it's fantastic discussions in this group.
Yeah, I heard Brett use my name a lot, but fortunately there's an agreement. I think that's just because we have more gray hair than everybody else. I mean, I think that you make your mistakes and you learn from them. I've always said I don't make the same mistake twice, but I make lots of new mistakes. But I'll be honest with the panel, and I don't want to offend anybody. I can count on one hand in 35 years of times I've used circularized wires. I mean, I think there's better techniques, and if you do them lateral and you take the distal femur and flex it up, you can actually reduce the flexion without having, like when you do them supine, like I said, when you keep pulling more and more traction, you get more and more deformity. So I'll put in a percutaneous clamp once in a while, but then because I pay a lot of attention to the starting point and stuff, once I take it off, it rarely pops off. But again, maybe that's because I've made more than my share of mistakes than I've learned. But I think lateral starting point, nail, understand your nail. I agree with Brett. I mean, if you can do a piriformis nail and it's a difficult fracture, go for it, because it won't go anywhere. It'll stay right where you put it. And I think if you want to use circularized wires and clamps, that's fine, but you're limited to certain fracture patterns. They got to be like a spiral or long. You're not going to be able to do it with a transverse very well. You can't circularize. I don't think you can, unless you guys are really great technicians, but a transverse fracture. But so again, you're limited. So I think what everybody talked about today is actually true. You just have a plan A, a plan B, a plan C, a plan D, and then go through them quickly. You don't want to be one of these people where they come in and ask you what time you'll be done your morning case at 2 o'clock in the afternoon, right? You just want to move along and get a good reduction. I see some smiles, so people have been there. So,
Anybody else?
I think if you're going to start nailing these things lateral, you should start with shaft fractures so that you know what things look like, because it's a very different experience. And be facile with it when you're not really trying to reduce the distal fragment to the proximal piece. So started with simple shafts. I mean, for me, really any adolescent femoral shaft fracture, I go lateral. I don't like putting them on a fracture table for whatever reason, but you need to be comfortable doing it with something simple, then graduate to a subtroch where it's more difficult. Because sometimes the proximal piece is such a weird position that it's very difficult to find an appropriate starting point on the lateral.
So a couple of people in the chat have asked about like getting good x-rays, and the people are responding with typing, but I think that's a good kind of question because we brought it up quite a bit. And so Alan, do you mind, mentioning like what do you do position wise and how do you get your lateral appropriately?
So I do straight up lateral, not like a sloppy position. I prefer blanket rolls to a pegboard or a bean bag because I think you can fluoro through it a little bit easier. And then the limb that's down, I usually extend the hip so that when you're flexing the injured hip, you're getting it out of plane from the other femur. And then when I'm making my decisions on the start point, it's a cross table AP, and then the lateral, you'll have to find the appropriate amount of orbit or rainbow over the top, but I'll also tilt the unit so it really does mimic what you would have for the lateral on the fracture table. So it's sort of a cross table as opposed to straight up and down. And then I'm usually, if it's a troch starting nail that I'm doing, I do that sort of trochiformis spot on the AP. But on the lateral, I'm kind of looking to see where the head and neck meet the shaft. And I think on young people, it's almost like, not always, but sometimes it's literally translated. So you can't be anterior enough for the neck and still be in the shaft, sort of. So on some of them, you have to cheat and kind of figure it out. So, but it's really tilting and finding the correct orbit of the fluoro to get that starting point where you can see.
Would everyone agree that making sure that you can see before you prep and drape is key?
Yes.
I think that's a really good point. And the other point, though, before, but is that when you're doing these lateral, definitely has its massive advantages. But I've found that the biggest risk of doing them lateral is actually a malrotation. And it's really important to use those tips of getting the rotation right. The beauty of doing it supine traction is you normally know the knees are pointing to the roof. It's going to be pretty close. But when you're doing it lateral, you can obviously move the leg in any position when doing your distal cross bolt. So, and often that's after you've done a really hard reduction and operation, and you sort of think the operation's all done. It's got to whack some screws across distally and we're done. And it's always the part I find that, is often going back to needing revision afterwards is often the rotation. So just be very wary on using all those tips and tricks that have been discussed about getting the rotation correct.
Yeah, I think like Brett said, I think you just have to get good fluoroscopy. You're on the APL lateral, match them. It's not, it's what you said is true. Everyone says to me they don't want to do them out because I'm worried about rotation. But just, do them and use fluoro. And I tend to over ream them so that once the top is locked, I can still rotate the femur on the nail. So I don't want a really tight fit. I want to be able to rotate it just to get it right. But same thing with length. I mean, I think if you use a fracture table, you could over lengthen people. I think with this one, you just have to sort of decide. Sometimes use a radial pig ruler to figure out your length when they're really badly comminuted. But I don't, honestly, I mean, a lot of the people here do very difficult surgery and, SI screws and pedicle screws and everything else. Figuring out rotation is something you can learn. It's not that hard.
I think your point about over-reaming, or at least being aware of it, especially with the nails that do have a smaller radius of curvature where they are curved more, it makes it more difficult to change if you recognize a problem after it's locked proximally, essentially. So you have to be kind of like, I get anal retentive about checking back and forth, true lateral the knee, true lateral the neck once the proximal's in, and then make sure that if somebody else doing the distal interlocks isn't rotating the leg, the image is changing, not the patient leg, to avoid changing the rotation afterwards, because there's always like the handle can rotate the femur out, if in the lateral, like the knee can internally rotate just position wise. So it's just like anything, just being really super critical about each step, I think, is important.
Is everyone using 2 screws, 2 points of fixation proximally, 1, doesn't matter? Can you get your thoughts on that?
I'm not always using 2. For the most part, I think I do, but occasionally I'll just use a greater to lesser screw if it's a transverse subtroch. There's no comminution, nothing going up into the neck or trochanteric region.
Any other thoughts?
Yeah, I use more recon nails in younger patients because it's a smaller hole up top. I just don't like making a giant hole in the top of younger patients. But for the older patients, any cephalomedular nail with a single large screw into the head is probably fine. I think for the younger patients, a recon nail with 2 screws, and we've all been there. And there's times I can only get 1 screw in, and they seem to do fine too. I think that all the things we talked about are more important than the number of screws up top. I think if you got a good reduction, don't put a lot of stress on your nail and your screws, I think you're probably fine. But 2 would be optimal. And then distally, you could say the same thing, 1 or 2 screws, and depends on your philosophy. And I think that really, for me at least, depends on the morphology of the fracture, and it's a bone nail construct. And if it's a simple transverse or slightly oblique fracture, maybe they get 1 screw. If it's incredibly comminuted, they get 2. But just based on some old finite element stuff, but I can't tell you that that's right or wrong.
What about placement of screws proximally? So like I almost always put at least 1 screw up into the neck. But there's multiple options. Is anybody always using the recon option or never using the recon option unless they find a femoral neck fracture on imaging or after the fact? Like where's your proximal screw placement typically?
So on an older person, I will always use a hip fracture type nail, because it seems to me now and again, you'll see a subtroch and it's a subtroch on CT. There's no neck component. And then they come back to the office and you can see a little thing there and a little fracture line at the base of the neck. And I think it's more comforting to have something up into the head. So, and then on a young person, I'll do a recon nail, but I'll still put the screws into the head. It's just the occasion that somebody comes back with a neck shaft that was unrecognized, negative CT, no blood in the capsule or anything. It to me, if you're doing an antegrade nail, I would, on a polytrauma patient, I would always put the screws into the head.
Not only that is, as Alan, you mentioned, a lot of these patients are high risk of falls and further injuries in the future, the elderly. And, I treat them like my cancer patients, belts and braces. I'm always going to be spanning from the top of the head with a kephomedullary nail right down the whole length of the femur. Because just trying to avoid that next injury, that next fracture. And then it's just that's even going to be a harder operation if you've got a nail in and you haven't gone through the neck already. So.
Yeah, I think I'm saying always a lot tonight, and I apologize, but I always do put a screw up into the head. If I can get 2 recon, I do. If it's 1 recon, because like I'm also quoting Bob a lot or acknowledging Bob a lot. So 1 screw at least up into the head and neck, and then the transverse 1, or if it's a different nail, whatever. If they can get 2, they get 2. But I think what Andrew was saying, I think is what I think about for younger patients too. Like if you don't put something across their neck. So I've gone to Corey Collinges and everybody who was on that paper, like doing recons for everybody for the reason that Alan said, like if you have a missed neck, but also because as people age, they're going to get stress risers and they're going to get some relative osteoporosis of their neck. And so, I won't know if I've prevented somebody from getting a femoral neck fracture because it might be 30 years from now, and I'm not going to be practicing 30 years from now, but it makes me feel better. So.
Yeah. Andrew, you mentioned, Andrew Mills, you mentioned for subtrochs, you're going to treat closed, you put them on a fracture table, and then the ones you open, you're going to put them lateral. Have you ever had a scenario where you put someone on a fracture table and you weren't real confident that it would reduce closed? Have you made any changes based on that?
I don't know that I've done that, because I think like Dr. Schweitzer said in the chat, if it's one where I'm concerned about reduction, I'll position them supine with the free leg first. And I think that gives you a lot of freedom, to get a good reduction. So I haven't had that scenario yet. I guess the one kind of scenario that we haven't talked about, I guess, yet, other than mentioning a transverse fracture, and it's something that I kind of think about a little bit, is, is there, what do you do, or what does the panel think about like a transverse fracture and a bisphosphonate type of situation where it's an elderly person, they have a subtroch that might be hard to reduce. There's a biologic, quote unquote insult to doing an open reduction, but the flip side is you want it to be perfect because that's going to be one that's going to take you a long time to heal. And that's something that I've run into. That's a situation where I've done it lateral because I wanted it to be perfect. I'd be curious to know what the panel thinks about that.
I do them the way I usually do them, but having said that, probably one of the, as far as I remember, last 2 or 3 years, the only broken nail from a subtroch was a bisphosphonate fracture. And typical story, she had some prodromal pain, went out to the mailbox, and her leg gave out on her. And obviously, this has been a chronic thing. So I guess based on some work that Jolene and others have done, I do what I normally do, whatever it is, and then I've been sending them off for PTH. Post-op, they get an endocrinology consult. Does it make a difference? I don't know. Like Brad, I think I sleep better at night knowing that I did everything I possibly could. But yeah, I don't know that opening or not opening. I try not to open them because I believe there's a periosteal blood supply that I want to strip. But I mean, if you have to get it reduced, because they are going to take forever to heal. They're just going to take a really long time.
I think you do have to pay really close attention. There's actually a grading system as far as for atypical fractures, like how much varus the femur's in. And I've actually had to, like in those particular fractures, like done an acute osteotomy to get them out of varus, because I know that the likelihood of the nail breaking is super high. So I think just making sure if you do have a atypical, try to get as much of the femur on one film as you can, just to avoid missing an overall varus look to the femur. Or if you notice it when you're in the OR, then switch gears, because they will take forever and stuff will break.
Well, that was the NYU paper from Kenny Eagle. The only non-unions in hardware failure they had was when they were fixed in varus, and if they were fixed close to anatomic, they had no non-unions and no failures. So again, that's on us.
I think some of that varus is, sorry.
No, sorry, Alan. I was going to say, as I always mentioned, they're a different beast, aren't they? And they're the ones that, I'll always be much more aggressive with actually a formal open reduction, and I'll often put a lateral cortical plate on and plate them and get maximal compression laterally before nailing them. And even sometimes if the bone's looking abnormal, burring out some of that lateral cortex, again, a bit like Brett's talking about, but actually trying to do a little bit of a closing wedge osteotomy sort of thing, get maximal compression laterally, and then putting the nail in, because they're the ones that I've had the biggest problems with in terms of non-unions and nail breakages, like mentioned.
Yeah, it's unhealthy bone. It's dead bone essentially that's not helping you.
The endosteal bone is pretty thick there, and I think that's a lot of the varus is because it's difficult to ream and not have an eccentric reaming because the bone's so hard.
Yeah, I don't want to beat a dead horse. Do them lateral. You do them lateral, you can put your guide pin right up against the lateral cortex and you can ream the crap out of it. When you do them supine, your guide pin always heads medial and you ream out the medial side. So you've actually set yourself up for failure. But you can actually, Brett can test it. You can put them lateral and put your starting guide pin and lay it right along the lateral cortex. You can do whatever you want with it. It's so easy. But I don't disagree with you, Alan. If you just let it go where it wants to go, yeah, it's going to be hard. You got to remount that lateral sclerotic bone.
You just got to pay attention to it.
You mentioned over reaming. Do you over ream those proximally or right at the fracture site to kind of ream down that sclerotic bone?
I don't know that I do, because most of my really big canals distally because they're older patients, but no, I don't have a good answer for you on
that. We're getting kind of a lot of questions on just when I think, for most of us, elderly patients would get like a true hip fracture nail, like a cephalomedullary nail, and younger patients get recon nails. But we've had several people kind of ask, how do you make that distinction? Like, what's your cutoff? Why are you choosing a recon nail over a cephalomedullary nail if they accomplish the same thing? I know there was a paper out at UT Southwestern a while ago that showed that they were both kind of the same in terms of reduction and healing and stuff. So, why make that big distinction?
I think reaming for a big screw on a young person is difficult. And sometimes the bone is so hard you can't advance the reamer. And sometimes, despite reaming, you can't advance the screw. And you'll need to tap it, which is
The helical blade
seems weird. Yeah.
trying to smash that
Well,
thing
I
up on a
don't.
good bone.
I mean, I actually never use that implant, but it's like the screws can be almost impossible to advance, or they'll incarcerate. So, if they're in their 20s or 30s, a recon nail completely obviates that as a problem. But if they're in their 50s or older, then I'd say use the hip fracture nail. You generally don't have the quite so dense bone.
You're gonna remount my truck.
I take umbrage to the.
I'm 50, but it's just like the people who
Let's say
show up
like
to the
60.
hospital tend to be less healthy.
Let's go
So-
60.
Okay, 60. Does that make you feel better?
Yeah.
I don't take out a large percentage of nails after subtrocks, but I do take out some. And so especially in the younger patients, just like Dr. Afsari said, I stay far away from the hip nails because I don't want to leave a big stress riser in the neck and a big hole in the head when I take out that nail. So I rarely use a hip nail in anybody under 60, I'd say. Maybe in even older people, I'll tend to use a recon nail unless the fracture is very proximal, because there is a variability in how high or low that fracture is going to be and still be in the subtrochanteric region. So if it's a reverse obliquity, then I'm much more likely to use a hip nail. If it's a high subtroch, then for an older patient, a hip nail. But if not, even in an older patient, a recon nail, or like I said, in a young patient, I do not always use a recon nail. I'll sometimes use just a screw, a locking construct that doesn't go into the head.
So upcoming journal clubs in June, I'll discuss MEPO techniques. In July, elbow fractures, and then in August, pelvic ring resuscitation. If you're interested in helping out with journal club, there's an email below. Also, there's a MyOA app that you can download to make this a little easier and get involved. There's also a case folio application where you can save some of your cases. It's a secure location to kind of help keep you organized. And then the link to the recording for this journal club will be sent out in 24 hours, and you can access it in these locations if you missed part of it, or if you just want to go back and listen again. So I appreciate for everyone who participated. Thank you for your time, and have a good evening.